We are honored to have.
So generally, my group doesn't just take one disease at a time. So we are trying to understand the molecular genetic landscape of in India for the very first time. We are leading India's most systematic study to understand the genetic architecture of this syndrome. So this is where my team focuses heavily on developing. A person has up to 80% lifetime risk of developing. It means even if you just have one faulty copy of the DNA, you are predisposed to developing cancer throughout your lifetime. Analytically, it's very expensive to conduct a study of this scale. So male infertility, you might be surprised to hear.
What about the fetal loss?
But both mother and father can contribute to a scenario like this. The very next day, he gives me a check of 500 pounds. Stay healthy, eat good food, get good sleep, take care of your health. Science can wait, your health can't.
Today on Genetic Education Podcast, Raw and Real, we are in discussion with a scientist who is shaping the landscape of human genetics in India. We are honored to have Dr. Harsh Sheth. Welcome, Dr. Harsh.
Thank you so much, Dr. Tushar, to have me on the platform and for that very kind and generous introduction.
Thank you, sir. Thank you so much. Dr. Harsh is Associate Professor and Head of Advanced Genomic Technologies Division at FRIGE Institute of Human Genetics, which is India's prestigious organization, where he works for futuristic next generation and long read sequencing technologies. He has secured over 25 competitive grants, authored 46 peer-reviewed research papers, contributed to book chapters, delivered dozens of talks, supervised more than 45 research scholars, and holds a patent in cutting-edge genomics technologies. His core research area includes infertility, reproductive medicines, oncology, and rare genetic diseases. Once again, Dr. Harsh, we are truly honored to have you with us on Genetic Education Podcast.
Thank you, Dr. Tushar. It's a pleasure.
Yeah, sir, let's begin our discussion with something very simple yet foundational. Could you share on which research project currently you are working on?
Right. So generally, my group doesn't just take one disease at a time. My group believes that genomic technologies can help us resolve multiple different questions all at the same time because the underlying technology that is required to understand them is very, very similar. So we begin with colorectal cancer and hereditary cancer syndrome known as Lynch syndrome, which actually is one of the most common cancer predisposition syndrome in the world, occurs in about 1 in 300, every 300 people in the general population. So we are trying to understand the molecular genetic landscape of this cancer predisposition syndrome in India for the very first time. We are using a very systematic approach to this. So that's an epidemiological style study. At the same time, my group led India's first systematic approach to understanding the genetic architecture of autism spectrum disorder using a whole host of genetic technologies. In fact, all of that data is now out. It also led to a substantial change in the way clinical practice is being done, not only in India, but throughout the world as well. Then we move on to male infertility, which surprisingly is a very, very common problem, but it's kind of buried under a hatchet because of a whole host of social dilemmas and issues that come along with it. So again, we are leading India's most systematic study to understand the genetic architecture of this syndrome. And in fact, the data for all of that is going to be made public very, very soon. We then move on to the realm of rare diseases. So this is where things like lysosomal storage disorders or hereditary inborn errors of metabolism kicks in. So this is where diagnosis is a key challenge, and all the existing tools that we have at our disposal are too expensive. So this is where my team focuses heavily on developing next generation technologies or leveraging existing technologies and try to find solutions to make it cheaper, more affordable for the people. And we have developed several patents around those.
So let's discuss each one by one, and let's start with the Lynch syndrome. What is Lynch syndrome and what is the status in India?
All right. So let's begin with the syndrome in itself. So I think everybody knows very well about hereditary breast cancer. So this is where breast cancer occurs in multiple female members of a family. Similar to that, there is a syndrome known as Lynch syndrome. So this is where a person has up to 80% lifetime risk of developing several different cancers, but most notably, they come with colorectal cancer, endometrial cancer, the upper GI cancer. So you're talking about stomach, liver, pancreas, and so on and so forth, right? And it's these sort of syndromes are what we call autosomal dominant. It means even if you just have one faulty copy of the DNA, you are predisposed to developing cancer throughout your lifetime. Now, this disease, according to WHO, occurs at a frequency of about 1 in every 300 people in the general population. To put it in the Indian context, it means that there are 46 to 47 lakh people with this disease right now in this country, but less than 10% of them are known to the medical services because we are so heavily focused on looking at colorectal cancer that majority
Okay.
of the patients kind of get left behind. We are more focused on treatment rather than actually identifying why they're getting cancers in the very first place. So this is where my group really kicks in to try and understand why somebody developed cancer in the very first place. And what we are understanding is that there are key genetic drivers that predisposes you to this sort of cancer predisposition syndrome, how we can identify them, how we can even prevent cancers in these individuals.
So I guess it is a combination of various types of cancer, is it?
Yes, that's correct.
So what is the process to know? Like it might be like combination of 3 or 4 type, or it might be only 2 types of cancer. So how you
Okay.
determine if it is a Lynch or something else?
Right. So historically, the way you would identify Lynch syndrome is that you would generally come across a family with multiple family members with either colorectal or endometrial cancer or cancers occurring at an age below 50 years or a very young age. Say, for example, a gentleman comes in your clinic at the age of 20 or 30 odd years and he has colorectal cancer. And that's kind of like a small alarm bell to tell you that he might be a Lynch syndrome carrier. But this kind of gives you a false sensitivity because in multiple scenarios, it turns out that you can look at the biology of the tumor in great detail to tell you that it's a hereditary cancer. And that biology is known as microsatellite instability. Put it in simple words, whenever we are typing on our phone, right, and we make an error, a spelling mistake, our
Hmm.
phone tells us that there is a spelling mistake. It tells us how to correct. In the same way, when our DNA is making a copy of itself, sometimes in making that during the copying process, it makes a few errors. And these mismatch repair systems are there to make these corrections for us. In Lynch syndrome patients, however, these repair systems are completely defunct.
Okay.
So because of that, you now get cancer at a very, very early stage. So the best way to identify these patients is actually by looking at the DNA in the tumor, and you get a signal what is known as microsatellite instability. So if a
Hmm.
patient has microsatellite unstable tumor, they're very likely to be Lynch syndrome carriers.
Okay. Okay. That's interesting. I guess it's also novel kind of study in India because as per my knowledge, very few scientists are working on Lynch syndrome because of the complexity, what I understand.
Exactly. Exactly. The reason is it's clinically challenging to analyze
Hmm.
it. Analytically, it's very expensive to conduct a study of this scale. And to do it at an epidemiological proportion actually requires vast amount of resources.
Hmm.
So what our group has done is develop several different approaches to kind of tackle these problems simultaneously. So
Hmm.
essentially build multi-institutional collaborations, work on not just colorectal, but work on pan solid tumors. So not just so you have endometrial, ovarian, stomach, liver, pancreas, small intestine. Look at all of them in one go. So it
Okay.
gives you much more robust estimate of how many Lynch syndrome tumors are actually there in the population.
Okay. Interesting. Okay. Let's move to the biggest challenge right now in India, which is male infertility. So what our research is what our research is unfolding the story. I mean,
Right.
what we have done and what is the scenario in India right now.
So, male infertility, you might be surprised to hear that it has an incidence of about 1 in every 30 male in the general population. So, that
Okay. In
means
India.
one in India. So, that means 1.2 crore males as of right now
Hmm.
are infertile. Now, there are a
Okay.
whole host of factors why somebody could be infertile. It could be diet, some sort of trauma, you can have endocrine dysfunction. But in about a quarter of these patients, you'll find a genetic defect.
Hmm.
Now, since these, a lot of work went into just looking at DNA from a very broad perspective. So, you would just look at the karyotype and you would say, aha, you have an extra two X chromosomes and one Y chromosome, which is known as Klinefelter. So that's kind of like the most common syndrome you would identify. The next one occurred in 1990s when people started to look at Y chromosome in a lot more detail, and they recognized that the bottom part of Y chromosome, what we call as YQ arm, if there are deletions there are genes that are required for sperms to generate properly. So if they are deleted, you end up with no sperms at all.
Okay.
And since 1990s, WHO recommended just do karyotyping, just do Y microdeletion, and you will be perfectly fine. But come 2008, and new sequencing technologies start to kick in, and we identify that it's not just one or two genes. There are a whole host of genes that are
Hmm.
involved in infertility. And our group, since 2017, has been working in male infertility. In fact, we identified quite a few genes ourselves in collaboration with Newcastle University and Edinburgh University right now. So what we did is, coming back to India, our question was very simple. Are these traditional technologies still required, or do we need to develop something more robust to get to the answer? So for that, we developed an assay, a sequencing based assay that can do Klinefelter detection, that can do Y chromosome microdeletion detection. But apart from that, it can screen 18 other genes simultaneously to
Okay.
tell you what is the genetic cause. Because once you identify the cause, the sort of IVF treatment you use changes quite radically. It also guides its
Hmm.
success or failure. So knowing the cause actually helps you in a much more better way towards its treatment.
So is it NGS based assays or
These are
something
these are
else?
NGS based assays. So
Okay.
traditionally, when you do karyotyping and YQ microdeletion, the cost somewhere comes around uh, 8 to 10,000 rupees. The same sequencing assay costs 10,000 rupees, but you
Hmm.
are getting a lot more information
Information. Yes.
that you would traditionally do. That
Hmm.
increases your yield quite dramatically, and therefore the patients don't just go round and round in iterative cycles of IVF. They know which one to use, when to use, and what are the success rates.
And what about the fetal loss? Because I read your paper on chromosomal abnormalities on fetal loss. So what is the status for fetal loss?
Right. So I think you're referring to the 2013 paper
Yes, yes.
that Dr. Frenichette actually led the entire study. So this, even today, is the largest study ever conducted on what we call repeated fetal loss.
Hmm.
Medically speaking, this is where the couples are fertile. They're able to conceive a child, but for some reason, the child dies in the womb itself during pregnancy. And again, historically, a whole host of factors have been associated with it. In about 4 to 5% of the cases, there was some issue that we consistently identified in the DNA of the fetus. So what we wanted to understand was whether they were inherited from the parent. So was there something wrong with the parent to begin with? Or was it de novo? It means it just happened by chance in the child. And what that study ended up showing us is that a good proportion of issues that we find are de novo. It means the issue is only restricted to the child. It hasn't been inherited. But there are cases, about 4% of the couples,
Hmm.
where they have, pardon me, they have issues in the DNA. Either the husband has it or the wife has it, or both of them have it, where
Hmm.
the DNA have grossly shuffled around. And
Okay.
because of that, they don't have the problem. When all the DNA is inherited, the child has imbalance in the DNA quantity. And because of that,
Hmm.
they pass away in the womb.
So you are trying to say there is no any environmental factor in that cases of pregnancy loss, not environmental factors, but the genetic composition of the fetus itself is
Is
responsible.
faulty. Yes. So
Okay.
genetic composition of the child is faulty in itself, because of which the child is not able to grow. In fact, following on from that, right now we are leading India's biggest study to
Hmm.
really dig deeper. So far we just focused on karyotype, right? Looking at DNA from a very
Hmm.
broad
Hmm.
perspective. Now with the technologies that are available to us, we can peer down to a single letter resolution
Hmm.
of DNA. So that's exactly what we are now trying to answer. Are the single letter changes in the DNA, what we call mutations, that can lead
Hmm.
to repeated fetal loss? So that study is ongoing. This is where we are looking at more than 100 such couples. And we are
Okay.
analyzing the fetus as well to really understand why something is occurring and which technology would be ideal going into the future to help these couples understand the cause and therefore give them a successful pregnancy next time around.
This study might be like this research might be a groundbreaking in coming times Because what I know personally is that only mother's genetic constituent might be responsible for the fetal loss. But this is something new, that the child's genetic composition, it might be like at a chromosomal level or possibly at a gene level. If
Yeah,
something wrong happen, that leads to fetal loss as well. So
absolutely. And
that's okay,
just
sir.
one
Continue.
correction, Dr. Tushar. It's not
Yes, sir.
just the mother, but both mother and father can contribute to a scenario like this
Okay.
at a chromosomal level. So
Hmm.
we are now coming to a point is looking at really fine-grained resolution to understand why this is happening. Because
Hmm.
looking at chromosomes, it just gives you kind of like a very broad perspective.
Broad perspective. Yes, exactly.
This helps us to really narrow down to the foundational level to understand what's happening.
Hmm. Okay. Okay. Interesting, sir. This is something new. Okay. Coming to very crucial part, you already mentioned many time about the technologies that you are developing at the Fridge House. Okay, and possibly that is focusing majorly on the next generation sequencing
Right.
and the long read sequencing. So how these technologies are will help the patient, and what actually you are developing at the Fridge House?
So as I said in the very beginning, there are multiple ways to sequence your DNA, right? But the most standard approach that is used is you take a piece of DNA, chop it into really small bits of about 100 letters at a time, you sequence them, and just like a jigsaw puzzle, you bring it all back together using a computer. Now, even though this technology has been around since 2008, the cost has plummeted quite well, but it's still not affordable for the masses in India, right? Because these tests can cost anywhere from 15,000 to 20,000 per individual. And even though these are really groundbreaking technologies in themselves, they're not error. They are error prone, and they can
Hmm.
miss certain regions. So to counter this entire issue, we came up with, again, we used short read sequencing technology itself, but we made certain really important tweaks into the way we analyze the DNA, right? How we capture the DNA, how we sequence it, and then how we analyze it on a computer. And
Hmm.
using that, the very first technology that our group developed was what is known as NGS-based microsatellite instability assay. So this is something that helps you to identify patient with Lynch syndrome. So this
Hmm.
assay was jointly developed with Newcastle University. I'm very happy to say it is patent protected internationally, and it got translated, and it's currently being piloted out across the UK's National Health Service as we speak.
Okay. Okay.
Then coming on to second technology, we
Hmm.
really started to hone down on lysosomal storage disorder, because that is one scenario where traditionally people would use biochemical assays, but it's also iterative in nature. So we
Hmm.
developed this technology to identify 23 such 29 such lysosomal storage disorders simultaneously using just one assay. And the cost of it is 10,000 rupees. Not only that, the yield is actually far superior than the biggest short read sequencing assay, what we now call whole exome sequencing. So whole exome sequencing has a diagnostic yield of 60%. It means if 10 patients come, I'm able to give answer for a genetic cause in 6 of them. Our assay has 83% yield. It means for every 10 patients who walk in, I'm able to give answers to 8 of them. So
Hmm.
this
Hmm.
assay again got patent protected. It's under commercialization at the moment. But as we speak, we also have a collaboration with Sanofi, which is one of the biggest pharmaceutical companies in the world. And we run a program known as Disha program, whereby any patient who is diagnosed with 5 common lysosomal storage disorder, they receive
Hmm.
free of cost genetic diagnosis. They don't pay a
Okay.
single
In India or in Gujarat only?
in India, across India.
Okay. 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 Let me just add something to your topic for students' knowledge, that NGS is a very expensive technology. It requires very high end expertise to standardize the assay, to run the assay, and lower down the cost. It's a high throughput technology, and it is like extremely costly technology. So whatever Dr. Harsh is saying is extremely tedious job to do. Okay, so to all the students, please strengthen your knowledge, strengthen your skills on NGS. Okay, sir. Moving ahead, you mentioned about Newcastle University. So, can you share any of your experience or any story which shape you as a scientist, which shape
Right.
you as a researcher?
So, well, just as a disclaimer, I did my undergraduate degree and my PhD as well as my postdoc all at Newcastle. I was in UK for 11 years.
Okay.
because I was very fortunate to receive fellowship when I applied for it to be there and study without spending a single penny. One story that has stayed particularly with me throughout all this time is with my mentor, Sir John Byrne. Way back in 2011, I just finished my undergrad degree. I was enrolled on a PhD program, but there was about 6 months gap for it to kick in. So I had no money in my bank account, and I needed to bridge something for 6 months. So one fine day, I went up to him and I said, "Could you give me any job, right, so that I can bridge these 6 months until my fellowship kicks in?" So he's like, "Okay, don't worry, meet me tomorrow." The very next day, he gives me a check of £500. That's equivalent to 50,000 rupees in
Hmm.
today's. He's like, "Look, this is your salary for the first month. I'm putting you as a laboratory scientist in one of my companies, and as you go along, we'll take a little bit of money out of your salary each month until that £500 check is completely void." And then on top of that, he gave me £1,000 check from his personal account to say,
Okay.
"Don't go hungry, eat properly, okay? Just build up your strength, because PhD journey is a very long one." And that stayed with me for a long while, because he had only known me for 6 months by then. And for him, it was an incredibly kind gesture. Of course, I repaid all the money back within just 1.5 months. But this was a pretty stoic moment for myself, because what it showed is the role of mentor for the student. It's not just to give knowledge, but it's also to nurture them when the going gets tough for the student. And this is exactly what I hopefully try and do for the next generation as well. I have 3 PhD students of my own, and there are times when they face difficulty. And this one moment always reminds me that what will Sir John do in this situation? And I try and emulate the answer that comes to my head.
Interesting, sir. Very inspirational story. We are also trying to do that because I'm also privileged to did my PhD with very ease.
Right.
Comfortably, I did it. But I found out that many students are struggling with their skills and potential they have. And that's why we started genetic education. We guide them. We provide them all the information, all the knowledge.
Of course.
We connect them with expert as well, and that is actually our duty when we complete doctorate or we entered as a mentor. So that is, as you mentioned, it is our duty to support the next generation of scientists, and then only they will grow
Of
and they
course.
will do some fruitful work for our country. Okay, last question, sir. Any
Sure.
advice for future generation scientists, how they will start their journey and how they will do some groundbreaking work in the field of genetics?
Sure. So, three very, very simple pieces of advice that I generally give even to my students. First one, please stay healthy. Eat good food, get good sleep, take care of your health. If that requires you to do some sports, please do that. Science can wait, your health can't. So, build up your
That's
strength when you're doing.
I'm interrupting you for a while because it's very interesting point. No one yet focus on these 3 points: health, food, and sleep. It's very good point, sir.
Because sometimes in doing science, we forget. We have done all nighters during our
Yes, yes.
PhDs. But the key thing that always stays with me is, so yeah,
Okay.
sometimes when doing science, we forget about our health and we pay the price down the line.
Hmm.
I mean, we are in healthcare after all. And if we don't take care of our own health, what's the point of doing science? You can't do
Hmm.
science with a tired mind. So that's number one. Number two, get as many skills as you can. By that, I don't mean you just do internship willy nilly all over the place. If you are at one place, get one skill down properly. That means it
Hmm.
can be as simple as just doing DNA extractions again and again, or PCR again and again, or Sanger sequencing, or whatever it may be. But keep on doing that until it becomes your second nature. There are
Hmm.
times when I don't go into the lab for 6 months, but I have to go after 6 months period. So my hands are a little rusty, but it all comes screaming back because I have done these techniques for dog years. So it's easy to get back to. That's number two. And number three, please get good mentors for yourself. The biggest detriment of becoming a scientist over a long period is somebody finding a bad mentor.
Hmm.
Mentors are like your parents. So whenever you are seeking a mentor, see if they can replace your parents or they behave like your parents. That means They give you a good warning when you're doing something wrong, but they also give you a good thump on the back to say, well done, even when you have done something very little, but it makes them heavily proud. So find those mentors for yourself. I've been very
Oh,
fortunate to have many of
hmm.
those in my life, and I wish that you guys find those as well.
Okay, very interesting to talking with you, sir. Thank you so much for this discussion, and this will help students, researchers, and other scientists to understand the technology, to understand the scenario, the genetic scenario in India, as well as what kind of research is we are doing at India in India, and particularly in Gujarat. So from our side, we are truly honored, and thank you so much for joining us today, sir.
Thank you, Tushar Bhai. It's been an honor, and thank you for the kind invitation.
Yeah. Okay, sir. See you soon.
See you soon.